Hey, good evening, everybody. I'm sorry that the link wasn't working. I don't know what happened there. I'll have to go back and look at the announcement. It's possible that I didn't copy the link in correctly, which is weird. I haven't had that problem before. Sun's in just the right spot to be annoying to me. I think that's just about everybody. Well, I apologize for the link not working. I'll make sure it works next time. Hmm. Okay, so tonight, image production. We're going to look at image acquisition and evaluation. Let's see, everybody. So first thing we want to look over are the factors that are going to affect our radiographic quality. And of course, they're divided into three categories: receptor exposure, spatial resolution, and distortion. And on the left side of our chart, we all the different factors that go into our image production. And the X's on the right columns are going to denote that factor affecting receptor exposure, spatial resolution, or distortion. Okay. So we'll start with receptor exposure. Oh, thank you. Thank you. We're recording right now.
Recording in progress.
Good deal. All right. So beginning with receptor exposure. So we're going to take a quick look at how mass, KV, SID, grids, tube filtration, PowerPoint's not being shared. Well, snap. I guess it's a Monday for me. Sorry, guys. Let's see more. Share. Screen two. Okay. Here we go. How's that? That better? Good. Okay. All right. So get these factors here one by one. Mass is what we think of as the controlling factor for receptor exposure. Okay. It determines the quantity of radiation that's going to be used during an exposure. More mass equals more receptor exposure. Now, there are other factors that will influence receptor exposure, and there are adjustments that we can make of those other factors. But the one that we look at for controlling our exposure is going to be the MA and the time. KVP does influence receptor exposure by influencing and changing the average energies that we emit during the exposure. The higher our KV, the more transmitted radiation we're going to have during that exposure. The more X-rays that are transmitted through the patient and the part, the more receptor exposure we're going to have. Our SID will influence the receptor exposure because of the inverse square law. If we increase our SID, we're going to decrease the amount of radiation that reaches that particular collimated area. So, as we've learned with the inverse square law, the intensity of our beam of radiation will vary inversely to the square of the distance from the source. So, if we double our distance from an original exposure, a resultant area, just pick a spot here, that's going to equal 1 dose. So pick another spot here, it will be equivalent to a quarter of the dose because we've doubled the distance. Remember, the inverse of 2 or 2 over 1 is 1/2. You square that and it's 1/4. Tripling the distance, again, 3 over 1, the inverse of that is 1/3 squared equals 1/9 of the receptor exposure. Adding a grid reduces receptor exposure primarily by cleaning up and absorbing scatter that is leaving the patient. Now, that is not to say that all of the radiation that a grid removes from an exposure will be scatter radiation, but the greater percentage of it will be. And since it won't be reaching the receptor, we won't have uh, the same number of x-rays hitting the receptor. If we increase our grid ratio, we're going to clean up more scatter than we would with a lower grid ratio. So anytime we use a grid in order to compensate for that lack of exposure, we have to increase our technique. Lower grid ratios allow for more scatter to go through. Also, more of the transmitted radiation will make it through. And I know frequency does come up, and we do have a certain frequency that we like to use with CR when it comes to grids, but uh, we don't ever factor or consider frequency as a factor for adjusting our techniques. So if we go from a certain frequency grid and then go to a higher frequency grid, there's no conversion factor for that. The only conversion factor we have for grids is, of course, when we change grid ratio. Filtration. The filtration of our X-ray tube, in our for filtration in our X-ray tube and in our system allows for a removal of a great percentage of lower energy X-rays, and these are X-rays that we consider uh, to only be related to patient dose, meaning they would never make it through the part and the anatomy itself. So there is no possibility of of those x-rays ever being transmitted through the part. So it's better that we go ahead and remove those and keep them from striking the patient at all. So by changing the amount of filtration, of course, we reduce the number of x-rays during that exposure. So that's going to have a reduction on our receptor exposure as well. And remember, the federal regulations say that if our equipment is capable of being operated at any kV above 70, it must have a minimum total filtration of 2.5 millimeters of aluminum equivalent. We can always add more, but we should never have less than that. And of course, as the tube ages, with tungsten vaporization occurring inside those tubes and it coating the inside of the glass envelope, that inherent filtration will climb from 0.5 millimeters of aluminum equivalent up as the tube ages. Looking at beam restriction, when we collimate to a smaller area and irradiate a smaller area of tissue, we're going to reduce the amount of exposure to the receptor. Beam restriction, of course, reduces the field size. It reduces the amount of tissue that gets struck in the patient. This is going to ultimately reduce the probability of scatter production. The less tissue we interact with, the less likely we're going to have scatter being produced. However, because of that decrease of a radiation that's actually coming through the collimator, we do need to increase our technique. So the mass does need to go up. And this is really something that we have to consider when, perfect example. When you do a lumbar spine, lateral lumbar spine, you use a specific technique. When you go to do the spot, it's not good practice, nor is it a good idea to use the same technique that you used for the lateral L spine on the L5S1 spot, because we're collimating. We're going from, hopefully, we're going from about a 7, maybe 8 by 17 down to hopefully at least a 9 by 9 for the spot. So that big reduction in area that we're exposing is going to cause us to have to increase our technique. We're going to increase our KV for one, just because now instead of going through the abdomen for L1 through L4, part of L5, we're having to go through the pelvis to go through L5 and the sacrum. So KV has to go up, but because we're using that smaller area, because of collimation, our mass also has to increase. The anode heel effect. Now, this is based off of the line focus principle, and it is taken into consideration when manufacturing the X-ray tubes themselves. The anode and the angle of the anode is the greatest influencer of the anode heel effect. And when we look at our angle here, it's not very, because we're looking at a vertical portion. I mean, you can look at it this way. That's a smaller angle. This is a larger angle. Okay. I like to look at it from a standpoint where we have the disc itself that we're looking at. So what I would do in this case is draw a different line from this point vertically up. So the angle that we have there, forgive that line for not being straight, is different from that angle there. Well, that is awful. I should start from the top and go down. So that's a greater angle than this one. Okay. Now, the greater angle does allow for greater heat dissipation. We're gonna strike more of the anode with this big angle than we would with this one. The problem that we're gonna have comes with the recorded detail. The greater the angle that we have, the larger the effective focal spot will be. So the line focus principle finds a balance between heat dissipation and the ability for the anode to absorb a great quantity of heat while still maintaining a small effective focal spot to reduce penumbra and increase recorded detail. So the smaller this angle is, the smaller the effective focal spot size, which means our recorded detail is going to increase. The problem with that is because all of our X-rays and the electrons that strike the target do not hit the surface of that target, they actually travel several atomic layers into the anode for some interactions. And so consequently, some of those may interact with another part of the anode down in this area and not make it out through the opening. Like we do here, we have less of that anode heel. This, by the way, being the heel. Less of that heel is interacting with our X-ray beam. So we're going to have more X-rays that are going to be emitted from this tube, from tube B, than we will tube A. Because of this, it's a good idea to position the patients with the thicker portion or the denser portion of their anatomy beneath the cathode. Okay. A perfect example of this would be with a chest X-ray or an APT spine. Okay. Look at your rooms. Go to whenever you're out in clinic. Go look at your rooms. Find where the anode is. Then see where you put the head of the patient. And more than likely, the anode will be positioned at the head end of the patient. When you turn the tube up to shoot horizontally at a wall board, greater percentage of the time, the anode is going to be positioned up as opposed to down. That's because for PA chests, you're thinner at the top than you are at the bottom. Now, at 72 inches, it doesn't make that big a difference. But for an APT spine, when you're shooting at 40 inches, there is a greater chance of the anode heel effect actually coming into play. And so when we think about the anode heel effect, it's more effective, it's more evident when we use a large image receptor combined with a short SID. When we use a longer SID, it's not as evident as it is when we're using a short SID. When we use a small collimated area, again, it's not as evident. But our tip here is to place the denser, thicker objects near the cathode side. Now, regarding the anatomy, of course, that's going to influence how much receptor exposure we get. Um, Anatomy, the thickness of it, the density, and the atomic number of the tissues that comprise the anatomy will all influence receptor exposure. If we have an increase in tissue thickness, we're going to get less exposure. An increase in the atomic number, we're going to have less exposure. An increase in tissue density, we're going to have a decrease in exposure. And vice versa. Another thing to consider with our patients is any pathology. So we have a chart here for additive conditions and destructive conditions, and in the different sections: abdomen, chest, skeleton, and non-specified sites. And for the most part, fairly easy if you can remember what that particular type of anatomy is and what it does to the tissue itself. It's kind of easy to remember additive or destructive. The only two where you really have to pay attention are going to be down here with in the skeletal system here with our metastases. If it's osteoblastic in nature, that means it's causing the body to produce more bone cells. It's going to be an additive condition. If the metastasis is an osteolytic type of cancer, then the bone cells are going to be destroyed and it's easier to penetrate, that hence destructive condition. The other one is Paget's disease. Late stage Paget's disease is considered an additive condition, whereas early stage Paget's disease is a destructive condition. Non-specified sites, these pathologies can occur in different areas and affect multiple areas, uh, depending on their severity. So this is a good chart to have. So additive pathologies, they're going to absorb more x-rays. A lot of instances, we're either going to need to apply more mass or we're going to need to increase our KV. Destructive pathologies are going to allow for more transmission. So we may have to pull back our technique. We may have to either lower the KV or lower the mass. Any questions about receptor exposure and those factors that affect receptor exposure? That's not an emphatic no, Miss Ramos, or I'm sorry, not yeah, Miss Ramos. No, who was that? It said no, Miss Roque. Sorry. Additive equals more technique. Yes, additive pathologies will require more technique. All right, so moving on to spatial resolution. So here we're going to look at OID, uh, SID, focal spot size, motion, and patient factors, along with two-part alignment. So remember, your OID is the object to image receptor distance. The further away that the object or the anatomy of interest is from the image receptor, the more our spatial resolution will decrease. Now, this will lead to one of our size distortions. Well, our only size distortion, actually, magnification. But it also, in particular, where we're talking about spatial resolution, we're talking about the amount of false shadow or penumbra, or the unsharpness of our edges. So the closer we can get our object, the lower our OID, the less and smaller the area of unsharpness. Okay. Now, unfortunately, or fortunately, because all of our anatomy is contained within this soft tissue meat bag, we're never going to have a zero OID. There's always going to be, and especially with big parts, because we've got uh, the table and then the bucky tray where our receptor sits. So there's OID there already, and then the patient sits on the table and their soft tissue, etc. So minimizing the amount of magnification is going to be paramount, and that's why we do some things PA, some things AP. Come on over. Now, SID. As our SID increases, the spatial resolution is going to increase. This is because at a longer SID, we have less beam divergence. So if we have the same size object, like we do here in A and B, the OID is the same. Okay, that measurable distance from the object to the film or image receptor is the same in both cases. The difference here is how far are we from the source. And because of that short distance, we have to have more beam divergence to get out to the edge of that object. Remember, if we don't get to the edge, we don't see the whole object. So by increasing the SID, we get more of a vertical beam divergence and subsequently less penumbra than we do with the short SID. Okay, now obvious first question is, well, why don't we do everything at the longer SID? And part of that has to do with radiation protection, that skin entrance dose. And the other thing is, it's not practical to do patients on a table that, in a lot of cases, is almost 3 feet tall. So, if you're 6 foot tall, putting the patient on a 3 foot tall table, they're already at half your height. And to go 6 feet above them, another 72 inches, um, you're going to have a ladder or a stage or some sort of uh, way to get elevated to push the tube up that high. Do everything at the wallboard. Of course, we can't do that because trauma, right? But again, it does come back to patient protection as well. So our shorter SID gives us decreased spatial resolution. It gives us a greater amount of magnification. Our focal spot size, small focal spot, gives us an increase in our sharpness and therefore an improvement in our spatial resolution. With a large focal spot, we're going to decrease that sharpness. We're going to get a decrease in spatial resolution, but the trade-off here again is it has to do with the equipment and uh, making it last as long as it possibly can. Because obviously, if we want to get the most spatial resolution, we would use the small focal spot. But throwing 150, 200 mass, uh, like we have to with some abdomens, some L spines, these larger patients, would cause um, heat fatigue on the anode, but especially on the filament. Because remember, we've got a small, thin piece of wire that we're heating up for thermionic emission to occur. And the more heat we apply, the more current we apply to that very thin filament, the more likely it is to break. Before all of our uh, light bulbs were LED or fluorescent, they were incandescent and they had a coil of wire in them. And after so many times of being turned off and turned on or running for hours and hours on end, eventually the filament would break. And of course, the bulb's not any good anymore and you have to replace the bulb. The same thing's going to occur with our X-ray tube. Um, so we have the large filament or the large focal spot to help mitigate those filaments breaking and extend the life of our X-ray unit. Motion. When we think of the one factor that does the most damage to our spatial resolution and can, just really make things awful, motion is that factor. Because our X-rays are emitted from the tube over a period of time. Now I know it's a fraction of a second. It's very, very fast exposures, and the X-rays are traveling very, very quickly through the atmosphere and through the tissue. The problem is, over a period of time, movement of a body part from one point to the next point occurs, and we'll get an image of that movement. And of course, that is extremely detrimental to our spatial resolution. We've got voluntary, involuntary, and equipment as far as the types of motion. Voluntary motion can be mitigated by using effective communication, having the patient and making sure the patient understands what it is that we as a technologist need for them to do so that we can be successful in getting them high quality diagnostic images. Involuntary motion is the type of motions that the patient has no control over. the heartbeat. We can't ask the patient to stop their heart while we take the chest x-ray. We compensate for that motion by using a very, very short time. Um, Muscle spasms. If a patient's been in an accident, they've had trauma, and the muscles are contracting without any control from the patient, that could be detrimental as well, depending on how hard that patient spasms. And then, of course, equipment. We really see the equipment motion when we're doing portables. On an older portable, maybe the locks don't work. The ER floor is a little wonky, and so gravity will tend to move some of the equipment. If we try to move it, rotate the tube stand, and it doesn't lock, it could drift during the exposure. So all of these things we're going to try our best to prevent from happening, because, like I said, the motion is very, 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 very bad for spatial resolution. Our patient factors, starting with size and pathology. If the patient's thickness increases, spatial resolution decreases. Again, their thickness, all the stuff that we're doing is inside the body. So if the thickness of the patient increases, the body part's not increasing in thickness per se. It's the OID. How far is that part getting away and drifting away from our receptor? That's going to cause a decrease in spatial resolution. Um, the amount of penumbra that we get here for the larger patients decreases our spatial resolution. Two-part film alignment, two-part image receptor alignment. Angulation, in a lot of cases, if we increase our angulation or go off axis, so we're not perpendicular to the part, it could cause size and shape distortion. Okay, and any type of distortion is, of course, not a true representation of the anatomy, and so it is a decrease uh, of spatial resolution. We want to make sure that we are shooting at the proper SID with the correct angle. There's some views, as we saw in procedures, especially with the skull, the foot, require an angle in order for us to project the parts in a specific manner for the radiologist to make his interpretation. And so when we deviate from those things, if we're supposed to have a 15-degree angle for the Caldwell, and we use a 20-degree angle on the Caldwell, and we end up with the Petrus ridges completely outside the orbit, that is an anomaly, and spatial resolution for that Caldwell has been decreased. Moving into our digital receptors, specifically the flat panels, the flat panel image receptors. Pixel size and pixel pitch. Okay. Now, pixel size, remember that the pixel, the word pixel actually stands for picture element, and it is used to describe the little squares that make up a digital image. In our image receptors, the term, because we haven't quite solidified all of our digital technology terms, a term that I'm seeing more frequently now is a DEXL. When we're speaking of the actual physical parts of the flat panel detector. So the DEXL, of course, would be detector element as opposed to picture element. But, right now, it's like I said, it's not, hasn't been solidified yet. But DEXL is a good I think that's a really good way to describe these as opposed to pixel. What you see here in A, those squares of gray, that would be individual pixels that make up that digital image. But our cassettes, our flat panels, have detector elements in them. They have thin film transistors and they have storage capacitors as well as a bunch of wires. So I think another word other than pixel definitely uh, in order here, but we'll go with pixel. Okay, so pixel size, the smaller we make our pixels for a specific field of view or image matrix, the more detail we're going to have, the better our spatial resolution is, as you see when A, B, and C. B is significantly better than A, but C is even better than B. And that's because the pixel size is getting smaller, which means the matrix for each one of these images is increasing. We've got more rows and columns of pixels as we go from left to right for A, B, and C. The drawing here is showing that by taking the same rows of and columns and reducing the pixel size, we're going to end up with a smaller field. So in order to make this field the same size as this field, we'll need to add more rows and columns. So our spatial resolution increases with pixel size decreasing. Now, pixel pitch refers to the measurement from the center of one pixel to the center of the next pixel. Okay, so this would be the pixel pitch. Okay, in this smaller pixeled matrix, this distance is shorter than that distance. So in that instance, a smaller pixel pitch would equal an increased spatial resolution. The problem that we run into is if we have two pixels that have a specific pitch at this size, and then we have two smaller pixels where the pitch is the same, that distance is the same as this distance, we're not going to have an increase in spatial resolution. Okay, the pixel is smaller, but because the pixel pitch didn't change, resolutions does not increase. Okay, we're going to have the same bit of information in each one of these pixels that we would have in these larger ones. So it's a combination of the pixel size and a lower pitch, which will increase spatial resolution. Merely lowering the pixel size, if we don't change the pixel pitch as well, spatial resolution doesn't change. Any questions about spatial resolution? Pass through these. Of course, I'm only a third of the way through the slides, but hopefully everything's coming through clear and you guys are understanding. Nothing? Okay. So let's move into distortion. We'll look at OID, SID, and patient factors and two-part angulation here. So distortion, of course, is any misrepresentation of size and shape of an object. OID which we looked at when we discussed spatial resolution, will affect distortion because of magnification and the magnification that it produces on the resultant image. Okay. So the greater the OID, the more magnification, the more distortion we'll have. If we look at this slide or this image down here, we see A having a large OID being projected to a large size on our image receptor. Object B physically is the same size as object A, but because of that decreased OID, it does not appear as large. So here we have two objects that are the same size within the anatomy, but because of the OID, one looks larger than the other. Then if we look at C, which is smaller physically than B, but because of that OID and its placement in the anatomy, it looks to be the same size as B. Okay, that's how OID is going to affect size distortion. Okay, so real quick now, we've got size distortion and shape distortion. Okay, there's only one type of size distortion, and that's magnification. Another thing that will affect magnification is our SID. So the farther we are, the greater the SID. Again, there's less beam divergence to get off to the edges of that object, so it is projected more vertically than it is with a shorter SID. So the shorter SID results in a magnified view of the anatomy as opposed to our larger SID. Lateral sternum. Lateral sternum is done at 72 inches because it sits in the middle of the chest and we have OID, a tremendous amount of OID. If we used 40-inch SID for a lateral sternum, yes, we would get a decent image of the sternum. But because of that OID, it's going to be magnified and we'll have to use a larger field. And of course, a larger field means we're going to have to, we'll irradiate more tissue, which means more scatter, which could obscure the recorded detail. So by using 72 inches for that SID, we reduce the amount of magnification that will result in the sternum, allowing us to keep that smaller field size. Patient factors, of course, are going to size and pathology. An increase in the size or thickness of the part can cause an increase in magnification because of the OID, because it's further away from the image receptor, just like we saw on the OID explanation. Some pathologies will make distortion more evident. The other type of distortion we get is shape distortion. A shape distortion is a result of an improper tube part image receptor alignment. Sometimes it's necessary. AP foot, right? A lot of their skull work. But other times, especially with other long bones, we would prefer to not have any foreshortening or elongation, right? So in this setup, our central ray is perpendicular to our image receptor and our part is parallel to the image receptor. So our angles are dead on, 90 degrees here. Okay, so our projected image, while not without some elongation and some magnification, will give us a fairly decent representation of the part, like we see here in A. Okay. Now, once we start angling the part, so our CR is still at 90 degrees, but the part and the long axis of the part is now angled, we'll start to see foreshortening here. So B and this setup here actually matches with this image B here underneath. Note the magnification of the humeral head because of the OID. There is some slight magnification of the distal humerus, but looking at the olecranon fossa in the humerus on both of them, you see there's distortion there. It's a little bit larger, it's elongated a little bit. Okay, so we definitely have a distortion here. Now, because the shaft is supposed to be this long and it's much, much shorter, that's where foreshortening comes from. So we get this B with B. So A matches A, B matches B. C, however, does not match C up here. The elongation we see in this one is a result of E. Okay. We've got a decrease in the OID at the humeral head, which is why it looks smaller here than it actually looks over here in A. We've got an increase in OID at the distal end, making the trochlea and the capitulum look much, much larger here. But we also have a lengthening of that long portion in the diaphysis of the humerus, hence the term elongation. Okay. So when the part is out of alignment, more than likely we will get foreshortening. When the eye image receptor, or if you want to look at it another way, we put an angle on the CR, we're going to end up with elongation. And this is why the angles that we talked about in procedures, we need to be precise with those. Any questions about that first section? We're going to move into technique charts. Now, technique charts are the pre-established standards or guidelines for techniques for radiographic procedures for a particular generator and imaging system. Okay, they are not universal. You cannot take one from one machine to another machine unless they are operating precisely in the same manner. That means their output for the techniques that are set are equal from machine to machine. Odds are they're not going to be, especially when, a lot of places, especially in my area, you may have a Toshiba in one room and a Philips in another room. And then, there may be a Shimatsu or a Swiss Ray. The different manufacturers, you can almost guarantee the output will not be the same for the techniques. And in the second lecture, we'll look more at how they test those outputs because that's part of the QC. So we have to have technique charts for each generator and imaging system. These are going to facilitate consistent image quality throughout all the different patient sizes, but they are based on the sthenic patient. Okay. So even if the centimeter size is different, the patient's larger, but they're still sthenic in nature. Okay. Um, these are very, very general. And of course, this is a pediatric exposure chart. And a lot of them, a lot of the new systems, they just come with a couple sheets of paper that spell this out. And they may have small, medium, large on them. But again, those are for sthenic patients. Um, and unless you really know how a generator works, you shouldn't take one chart to another room to utilize it. Aside from the technique charts, as advanced as imaging has become, you know, in let's see, 2009, 94, 96, 98, 2002, probably when we first got our digital systems in this area. So for the first 19 years or 10 years, first 10 years I was working as a technologist, I had a book that had techniques. It was a technique chart, but it had a book format to it. So, you'd find an AP foot. There was all the measurements and then the technique that you would use. If you were going to do an oblique, you had to turn the page and find the oblique. Say, and it had one of those for every body part, for every view that you would possibly do. Now we're reduced to a couple sheets of paper and general sizes, and the anatomically programmed techniques or anatomically programmed radiography, where we are able to press a button based on the body part that we're going to do. And once we select hip femur, the next thing that comes up would be the AP view or the lateral view or the distal femur. Um, that's anatomically programmed. Now they'll set up the KV, it'll set up an MA, and this one actually activates the AEC. So we're not even going to set a mask for this. The AEC is going to be utilized to make the exposure. And this is the way most APRs are set up. The only exception for those techniques being automatically exposure controlled in most cases is going to be whether or not you're using the Bucky or a Bucky. Okay. Um, the main thing you do need to remember again is these factors are going to be based on a sthenic patient, and that the technologist always has the option to change any of those technical factors as needed. Okay, we are in control. Computers are only as smart as the people that operate them. Now, going back to an actual technique charts, there are two different types. Me, myself, believe there should be three, but we're sticking with two. Okay. The first is called a fixed KV. The other is called a variable KV. Now, there's a second part that goes with each of those. If we're using a fixed KVP chart, that means the mass is going to be variable. It's going to change. If we're using a variable KVP chart, that indicates that the mass is going to remain constant. Okay. Now, with a fixed KV chart, we're going to maintain a specific KV for all of the different body sizes. And the mass will be adjusted for every 4 to 5 centimeter changes in part thickness. This is great for big body parts, abdomens, chests, pelvis, hips, anything where there's a big variance in the sizes of body parts that we see. Okay, not like a hand. Okay, you would not use a fixed KV chart on a hand. You could, but it's not best practice, because with these charts, we're going to use an optimal KV for the body part being imaged so that we make sure that it is high enough to go through the larger patient or the larger size. Still sthenic. I'm not talking about high BMI. We're just talking about large people. Okay. So these charts are going to be used for larger body parts. Accurate measurement of the part is not very crucial since we measure by centimeter thicknesses and they're lumped together in 4 to 5 centimeter jumps. So your technique doesn't change. If you've got 14, 15, 16, 17, and 18 centimeters are all going to use the same technique. If they're measuring 15, slight error, see a centimeter either way, keeps you at the same technique. So part measurement's not as crucial. With our variable KV, we're going to use the rule of thumb that states that for every centimeter change in part thickness, we will increase or decrease the KVP by 2. Okay. So if we're going from 14 sthenic patient to a 15 sthenic patient, we started off with 70 kV. We go from 14 to 15, we're going to go to 72 for the 15. Okay. These are most effective with small extremities and pediatric patients. Now, the reason for this is it's not uncommon to have an abdomen at 18 centimeters and then another abdomen come in at 34. Right? That's a lot of centimeters to go from 18 to 34. What you're not going to have is a hand that goes from 2 centimeters to 10. And that's only 8 steps, centimeter wise. So that would be 2 different techniques if we use the 4 to 5 centimeter rule for changing the mass. So with smaller body parts, especially extremities, we'll use the variable KV. Examples. So for 10, 11, 12, and 13 centimeter sized patients, we'll use 73 kV and 4 mass. Okay. Once we get to that next jump and that next grouping of 4 centimeter thicknesses, the mass jumps up by a factor of 2. Right. So 14, 15, 16, 17 are 8 mass. The next group, the mass jumps up again by a factor of 2. So this is the way these charts are constructed. Okay. So for every 4 to 5 centimeter groups, the mass changes by a factor of 2, while KV remains the same. In our variable KV, so again, we're going from 10 to 21, so that's 22 centimeter sizes that are probable, okay, based on this chart. From 10 to 15, there's only 6. Okay. Since there's only 6, it makes sense that we'll just increase the KV just a bump for every centimeter and maintain our mass. All right. Special considerations for a plaster cast. You're going to have to increase the technique for a plaster cast over the technique that's prescribed for that same size part. Okay. Without the cast. Right. In most cases, if it's a dry plaster cast, we will increase our mass. If it's wet, we're going to increase our KV. Okay. Wet plaster casts happen to be a little bit more dense because of the water. So we're going to have to increase our KV. When it's dry, that water is gone, so the atomic number is changed, and we can just increase our mass. Fiberglass casts, there's typically, for digital systems especially, there's typically no change that you will incorporate for those. For pathology, This is, don't get freaked out. These are the same pathologies. This is the same chart we saw earlier. Okay, so this isn't another set of pathologies. So for the additive conditions, it's prescribed that we increase our KV. An additive condition typically increases tissue density and the atomic number changes as well. All right. Uh, a lot of times an additive condition does not cause the soft tissue size of the part to increase. It's only the internal structure that increases or changes. Because the additive conditions affect the atomic number and tissue density. Remember what tissue density is a change in the amount of atoms within a certain volume of tissue. I like to think of this as a donut box. I describe it as a donut box with my students. If you take a dozen donuts and put them in a donut box, you've got so much donut and air within that box. If you take 2 dozen donuts and put them in that same size box, you're going to have to start to compress. You're going to have less air, more donut. Okay, that's what an additive condition does. So that the box size doesn't change, but there's more tissue in there as opposed to things that are easily penetrable. Um, so that's an additive condition. You get a dozen donuts in a box and take out 6 of them. Well, you've got a destructive condition now. There's less of the donut contained within that volume of tissue. So they're easier to penetrate. So in most cases, we're going to want to decrease our KV. There are some instances where the destruction is great enough, we may have to pull back on both mass and KV. Pediatrics, because they're smaller in size, they don't have that tissue density in their bones or all over for that matter. Um, we want to use lower KV and lower mass for pediatrics. Um, it's also not a good idea to use the AEC for anything that involves uh, imaging of which would require the use of the outer cells. Center cell, it's okay, but you still need to make an adjustment in your technique so that we can make up for their lack of tissue density. Geriatric patients, same thing. If they're frail, their muscles have atrophied, maybe they have osteoporosis, technical adjustments in KV may be required. And we drop the KV on geriatrics, remember, because according to our radiation protection, as we get older, your whole body cumulative dose increases every year. It goes up. Okay. So pediatrics, we want to drop KV and mass, combination of the two. With geriatric patients, we're okay just dropping the KV. Larger patients with a high BMI, we're going to need an increase in KV and mass. Definitely want to use a grid. We want to add grids where we would probably normally not use them. Okay. Um, Depending on their size and the exam or procedure being done, we may have to do them in sections. Because of that increased OID, some of those bones may not fit all on one image receptor, so we may end up having to do 2, and in the cases of abdomens, we may end up having to do 4. Other considerations, special considerations, especially contrast media. Your positive contrast agents change the absorbing properties of the tissues in which they're contained within. A positive contrast media will absorb more radiation. Okay. So we're going to have to increase our technical factors in order to get a good diagnostic image. Negative contrast agents, air, those effervescent crystals of magnesium citrate, they decrease the tissue density in a lot of cases by blowing it up and expanding it and moving it out. So now the tissue volume is not as great. So we'll want to decrease our technique for those. That's why with the solid column BE, we're going to go around 100 to 110 kV for those exams. And if we're doing an air contrast, we may go 80 to 90 in our kV. Grids, we got to increase our technique if we're going from a non-grid situation to a grid situation. If we're changing to a higher grid ratio, we're going to need an increase in our mass. There is a grid conversion formula for that. I hope you've seen that and you know the grid ratios and their conversion factors. If we have no grid, that has a factor of 1, not 0. Okay. So if we go from a uh, no grid to a 5-to-1 grid, which has a grid ratio of 2, we would simply double the mass. Okay. The formula really comes into play when you're going from a conversion factor of 2 to 3 or 2 to 4, 2 to 5, or vice versa. But when we're going from no grid to a grid or from a grid to no grid, you simply multiply or divide by whatever the grid ratio conversion factor is. Our automatic exposure control or automatic exposure devices are used to control the amount of radiation that reaches the IR by terminating the length of the exposure. Okay, so the ionization chamber that is utilized once a certain amount of electric charge is generated by ionization, that will send a signal to stop the KV and halt X-ray production. Okay. When we set up the AEC, it would be set up with a specific density that we're looking for, which corresponds to a specific amount of ionization, which corresponds to a specific charge that needs to be reached before. Otherwise, the machine's going to run until that predetermined level is reached. So, effects of changing the exposure factors on radiographic quality with our AEC. If it is operating properly, the radiographic quality should be the same for each view that you utilize the AEC for. If you're constantly having to make adjustments from, chest x-ray to chest x-ray, then there's probably something wrong with the AEC. It needs to get checked out. Now, based on pathology, the patient's body habitus, it may be necessary to adjust the amount of radiation that's required for the exposure. And you do that with the master density control, which is visible here. That square with the black and white triangles in it, that is our density control for the AEC. And this one goes to a +5 and down to a -5. So, a lot of the systems are set up so they're sitting at 0. In some instances, we may want to step up to a +2 or step down to a -3, depending on the patient, what the exam requirements are. So the master density allows for us to adjust the amount of radiation required for an exposure. By doing a minus density, we're going to have a quicker exposure. By doing a plus density, we're going to have a longer exposure. If we change our KV, increasing the KV just means we're going to have more penetration and we're going to have a shorter exposure. Okay. Increasing the MA means we're going to be producing more x-rays initially during the exposure, which will allow for a shorter exposure. Now, if we want a longer exposure, you can drop your KV. That'll cause it to run longer. Or you can drop the MA, which will also increase the time. Now, best case scenario is if you have to do a large increase or decrease in the amount of radiation that you're using, um, or actually, let me scratch that last sentence. Adjusting the KV and the MA is for adjusting how long the AEC operates. Short exposure, long exposure. All right. If you need to change the amount of radiation that reaches the receptor, you need to change and adjust the master density. Adjusting your KV and adjusting your MA using the AEC doesn't change the amount of radiation that you're going to produce. Okay. Um, it adjusts the time of that exposure. Detector selection, very, very important. Choosing the wrong detector can cause improper exposure levels. Positioning is it paramount when using the AEC. I know lots of people that when they do L-spine series, they like to use the AEC for the whole series. I prefer to take an AP using the AEC, then use that technique as a reference, make an adjustment, and do my obliques. Because lumbar spine obliques are a pain in the butt, period. I've been doing it for 30 plus years, and still getting that thing directly over the center of the cell, especially on larger patients, is not an easy task, even if you've been doing it for a long time. So, to make it easier and better for the patient, I manually adjust from my AP technique to my oblique technique. That way, I don't have to worry about being off of that center cell, because if you're using the AEC for an oblique and you get too far in the back or too far in the front, your image quality is going to suck. Okay. You're going to have an underexposed image. It's going to be noisy. It's going to be grainy. You're probably going to have to repeat it. All right. So for me, best practice is get that AP technique and then manually adjust for the obliques. And then if I can, I will go back and uh, use the AEC for the lateral and the spot. So again, this just reiterates that whole point, making sure that the whatever anatomy of interest is in the center or positioned over the cells that you are requiring. If you're doing a T-spine, of course you want the center cell. But if you're doing a chest x-ray, a PA chest x-ray, you want those two outside cells, not that center cell. So selection of the cells is going to be important as well. Be aware of prosthesis. Taking a patient history is so important in these cases, but you have to be aware that sometimes, and I had this happen. Have you had any surgery in your hips? No, but I had my gallbladder taken out so and so years ago. Okay, that's good. We go ahead, we do a pelvis, and bam, they've had a right hip replacement. Bipolar, both ends. Didn't remember having that surgery during the conversation. And the question, have you had surgery? Right? So, even if you do talk to the patient and they do give you an answer, sometimes things happen. In that case, we're looking at the pelvis, but we're going to be doing that hip because it's a pelvis and a hip examination. So it's a good thing we did the pelvis first. So now when I go, I can make either a manual technique for that hip with the prosthesis, or I can adjust the master density down so that it doesn't require as much radiation to make the exposure with the prosthesis, because the prosthesis is going to absorb the radiation and the machine is just going to keep running and running and running. And what typically happens is the bone that is around that prosthesis gets saturated with radiation. It gets burned out. And it's kind of can be windowed, but you're still not going to have the best image. So knowing that there's a prosthesis there, you could bump it down to a -2, -3 master density and make an exposure and not uh, have to worry about burning through the healthy anatomy that is there. Yes, the master density increases or decreases the amount of radiation for that exposure. It does so by lengthening or shortening the time, which we'll talk about in a second too, because that is another factor that we have to look at. So here's our master density control again. The typical adjustments is going to be at about 25% of the amount of radiation that's required for each step in either direction. Okay. So this would be 25% increase plus another 25% increase. It's not the same as a 50% increase. Okay. So it's 25% of what you need first, and then another 25% on top of that. Same thing here. Going minus, we're going to decrease the amount of radiation required for that exposure. Making that adjustment either positively or negatively is going to either increase the length of the exposure or decrease the length of the exposure. Okay. Now, there is a backup time that should be utilized with the AECs. This prevents excessive exposure to the patient in case of time switch failure or radiographer error. The most common radiographer error with the AEC is not aligning the Bucky to the central ray. Maybe we're doing an exam, we've got to have an angle. And we take off the angle and we go ahead and make the exposure without moving the Bucky and lining it back up. In that instance, the machine is just going to run until it hits the backup time. Okay. And federally mandated safety device limits the exposure to a maximum of 600 mass. Okay. So imagine if you've paid attention using the AEC, you'll know that if we use 120 kV on a high frequency generator or even a 3-phase 12 pulse generator, we're probably going to use for a sthenic patient at about 23 centimeters in thickness, we're probably going to use about 4 mass at 120 kV. Okay. Now, if you don't set a backup time, it is possible that they can receive 600 mass on an exposure if there's a mistake made. Okay. So we need to set a backup time. And the recommendation is usually about 150% of what we would use for a manual technique. So if we would use 4 mass, 50% of 4 is 2. So I would want to set a backup time that would be no less than 6 mass. Okay. You can go up to as much as 200. So 8 mass would be acceptable as well. But most of the machines I've seen, when you use the APR and it sets up the AEC, will give you a backup time of either 0.5, 0.7, or 1.0. Now that's 1 second. Okay. If your MA setup is 400 and you have a 1 second backup time, there is a possibility that a patient will be exposed to 400 mass. And if they only need 40 mass, you've overexposed them by a factor of 10. And if image resolution, spatial resolution and image quality is compromised, now you got to repeat it. Okay. So we should always be adjusting that and that's the reason why you need to be good at techniquing, and technique charts need to be utilized. You need to have good working techniques so that you can prevent, if all else fails, at least you won't overexpose the patient. So moving into our spatial resolution, looking at our digital imaging characteristics. Resolution is measured in line pairs per millimeter. Okay. Now, a line pair is, let me get my pointer up here. Pointer over here. A line pair, if we have a resolution or we have a set of lines, I know they're not straight. I'm sorry. Okay. So who would want to venture a guess of how many line pairs we have here? Just in that. Okay. And let's say that the distance between here and here is 1 millimeter. Okay. So how many line pairs for that 1 millimeter do we have? Line drawing. Six. Good. That's good. And that is correct. Now, if you thought 3, because I mean, that's a pair of lines, right? That's not correct, because a line pair consists of the line itself and the space that comes after it. That's what makes up the pair. Okay. So the next line that you see is actually it's half of the next subsequent line pair. So the more line pairs that you can fit in a millimeter and still appreciate, the better the resolution is. Okay. Now, some terms to know. The matrix. This is the rows and columns that make up our digital image. Okay. The pixel is the picture element. It is the individual square contained in a specific row, in a specific column, in a digital image. For a given field of view, we have a specific size that we're limited to. The more rows and columns we have, the larger the matrix. Okay. But in order to have more rows and columns, the pixel sizes have to be small. All right. So in this case, our resolution for a given field of view, the larger the image matrix, the better the spatial resolution, because the pixels are small. Okay. Now, moving into our pixel characteristics. We've looked at this already, but remember, the pixel size is its length and its width. Okay. The smaller those are, the smaller the pixels are. If the pixel pitch changes along with the pixel size, resolution is going to improve. Okay. If the pixel pitch does not change, meaning these pixels are further apart to match this distance, then resolution does not improve, even though the pixels are smaller. Our detector element, or the DEXEL, starting to refer to it. The detector element itself, in this slide, This slide is referring to the physical portion of the flat panel. It's referring to all of this as the detector element. It calls this green the pixel detector. Now, what we're working towards is calling all of this the Dexel, and calling this the DEL. And the reason for that is very simple. The green is either amorphous silicone or amorphous selenium. It's one of the two. It is one of the two elements, period. That's it. There's nothing else in there. So it only makes sense that it would be the detector element, because that's the element that detects the radio or the electromagnetic radiation coming into the flat panel. All right. So this is the area that is used to capture the electromagnetic radiation in the flat panel detector itself. Okay. Now, the indirect capture flat panels use amorphous silicone. I for indirect, Si, the chemical symbol for silicone, they go together. Okay. If it's an indirect capture, it's using silicone. All right. That requires scintillation, which means the x-rays that exit the patient need to be converted to visible light. Okay. They need to be converted to visible light because silicone reacts very well with visible light, much better than it does x-rays. So scintillation is required with an indirect capture system. A direct capture system is going to use amorphous selenium. All right, that's chemical symbol Se. And in the alphabet, E follows D. So direct selenium. All right, that reacts very well to x-rays. So no scintillation is required. The x-rays exit the body, go through the cassette or the lid of the detector, and react with the selenium, giving us an electric charge. So the smaller these items can be made, the smaller this is, theoretically, the spatial resolution will be better. But again, if the distance between them doesn't change, the spatial resolution doesn't change. Okay. Fill factor is used to describe the detective ability of these elements. All right. Because there is a thin film transistor and a storage capacitor that goes with each one of these detector elements, real estate is, limited. So we have a fill factor for how much silicone or selenium is going to be in each one of these elements. Typically, we're looking at 50 to 80% fill rate. Now, the fill factor, contrary to what this says, the higher the fill factor, the higher the spatial resolution is not true. That is I don't know why I have to have that in this slide, but this representation is not factual. This represents a specific area of anatomy. This represents a specific area of anatomy. In order for the signal to be a specific amount, we need to be able to detect the radiation. So what the fill factor does is it actually allows for a lowering of the amount of radiation that is required to get a diagnostic image where it doesn't appear noisy. Okay. So the fill factor, I mean, this is the size of the detector element. The detector elements are the same size, right? So if they're the same size, that means their pitch is the same, which means resolution doesn't change. So I would, if I were you, cross that line out about the higher fill factor, the higher the resolution. Okay. The higher the fill factor, the greater the fill factor, closer to 80%, the better it's going to be at um, collecting the radiation exiting the patient or being put out by the scintillator. This slide applies to CR. Okay. This is the sampling frequency, deals with the light that's being emitted from the image plate in the reader. Okay. We got a laser that scans the image plate and that causes it to give off light. That light goes in through a light guide into a photo detector and photo multiplier tube. And of course, then it gets converted to an electric signal out to the computer. The Nyquist theorem states that the sampling frequency must be greater than twice the frequency of the input signal. Okay. So the amount of radiation that we put to the plate, we need to sample 2 times more of that area than what we irradiated. So the laser needs to be very exact and the scan lines need to be very, very close together in order to hit this Nyquist uh, theorem requirement. If we don't, then we end up with the analog input signal peaking out at a specific area or a different area as opposed to along the same line of the signal coming in. This causes uh, an aliasing or an anti-aliasing in our image. Um, we look at that. The artifact that's created from that is called a moire, and it looks like you took 2 images and you kind of put them over one another, but they don't quite line up. Okay. Again, this is for CR. This does not apply to flat panel or CCDs. So again, for spatial resolution, for a given field of view, the larger the matrix, the better the resolution because the pixel size is smaller. And because the pixel size is smaller, but the matrix size is increasing, the pixel pitch consequently is smaller as well. So it works out good. The modulation transfer function. This is kind of this is a difficult concept here, but it measures the information that's lost between the subject and the image receptor. Now remember, the subject is 3-dimensional tissue. Okay, the subject is 3-dimensional tissue, and we're taking that part of it, right, and projecting it into an image receptor so that we get a representation of the anatomy internally. So if this is 100% of the information, we're only getting a small percentage recorded in our image. Okay. That's what the modulation transfer function describes. How accurately the analog information, this physical form, gets represented in our digital image. Okay. An MFT of 1 is perfect. That means if we did a lateral of a hand or my hand here, we would be able to see the skin, the nails, we would be able to see the hair, we could see the wrinkles in all the skin, everything, along with the bones, the vessels, the tendons, the ligaments. We don't have that luxury with X-ray in our imaging. We only get a portion of the anatomy in our images. So the MFT falls further away from 1. Okay, 1 is perfect. That's 100% of the information being transferred into the digital image. Okay, so when an MFT falls closer to 0, the less visibility of the structures that we have. The closer to 1 it is, the better the visibility of the structures. Contrast resolution is the ability for a detector to detect and convert the radiation signal into or the radiation into signal values, which in our case is going to be electrons. Right? It's an electric signal. These are going to be converted through an algorithm into different levels of gray. Okay. A low contrast resolution is a type of contrast that deals with the ability to record and display subtle energy differences. A very, very good low contrast resolution modality is MRI. MRI is so good with low contrast resolution and representing different shades of gray out of tissue that we can see brain matter, the white brain matter and the gray brain matter as two different, they give two different signals during the examination. With x-ray, do you see gray matter or white matter when we do a skull? No. We can see it if there's air, maybe air against the cranium, but that's a contrast resolution that doesn't have to do with the soft tissue or low contrast. That's a high contrast resolution. So that's what most of our x-ray stuff is. But talking about software, the bit depth for our computer software and our imaging software is going to determine the number of shades of gray that can be represented in that system. Okay. Um, because we're using binary and the machines and computers use a binary code, there are only two digits. There's only two integers. That's what a bit is. That's a binary integer. And there's only two of them. It's a 0 or a 1. 0 represents on or off, and 1 represents on. Okay, that's machine language. So electrons, electricity's flowing, or it's not. On, off, on, off. So in a 2-bit system, okay, in a 2-bit system, well, let's look at the 1-bit system. All right, in a 1-bit system, that means that there is only one space for a value. Okay, we denote that with, y'all call it the hashtag, but it is a £. So that represents a 1-bit system. And in place of that £, there can only be a 0 or there can be a 1. In a 1-bit system, if we convert those to shades of gray, it is either black or white. So there's only two values of shades of gray. If we go ahead and add another bit here, and so now we have 2 bits, so there's 2 spaces for a binary integer to go into. So we get 0, 0, 0, 1, 1, 0, or 1, 1. 4 values giving us black, white, and 2 shades of gray. Okay, one lighter than the other. Now, as we increase the number of integers that we're allowing in the system, the number of shades of gray increases exponentially. So with a 4-bit, now we got 16 shades of gray. 6-bit, 32 shades of gray, etc. Okay, so it keeps going up. Most of our imaging software operates at a 14-bit. Okay, it's a 14-bit software, and the bit depth is 14 bits, which means we can have 14 integers and combinations of binary integers that gives us roughly 16,000 different shades of gray. So the higher the bit depth, and this is the formula to calculate it if you needed to, the power of n, or 2 to the power of n. So 2 is the binary portion, and n is the number of bits that are included. DQE, again, talking about detective quantum efficiency. This is the percentage of incoming X-ray photons that are detected and absorbed by the detector for use in generation of our image. Okay. A detector system, an imaging system that has a high DQE requires less radiation than another system with a low DQE. Okay. The perfect device would have a DQE of 1. That means all of the radiation that comes out of the patient, we would use all of it to generate our images because it detects all of it, right? Most of our digital rad systems have DQEs of 0.3 to 0.7, which equates to 30 to 70%. Remember, a DQE of 1, a modulation transfer function of 1 is 100%. A DQE of 1 is 100%. Our digital rad systems vary anywhere from 30 to 70%. Remember that your grids are going to affect contrast resolution by not allowing scatter to reach the image receptor, depositing energy into areas that don't correspond to the anatomy in that area. Okay, so we get rid of the fog. It clears up. It improves our contrast resolution. So grids decrease scatter from reaching the image receptor and increase image contrast. If you need to go, rock on. Have a good evening. We only have a few more slides left here. And I am recording, so you're good to go if you need to. Otherwise, we're just going to keep going, okay? The image signal, a useful image captured by the detectors. The dynamic range refers to the range of exposures that a system can respond to. The more levels of exposure that the system can represent, the wider the dynamic range. Okay, so a digital receptor can respond to all of these different levels of exposure, where film may only be able to operate at these levels of exposure. So anything in here will generate an image on film. Anything less than this, the film won't even respond. Anything more than this, and the film is going to be completely black until it solarizes, in which case density decreases and it actually loses density. So this is the range of exposures that film can respond to. This is the range of exposures digital can respond to. This is the dynamic range, okay? Now, this is also exposure latitude. Digital systems have a wider exposure latitude because you don't have to be dead on exact in order to still get a workable image. With film, you needed to be closer to exact, otherwise it was underexposed or overexposed. And it's for this reason we are able to use lower techniques now with digital systems than we did with film. One thing that we do still have to watch out for in either system, no matter what imaging system we use, is quantum noise, otherwise known as quantum model. And the model is talking about that matted, grainy appearance. That's what model is. Quantum model refers to the fact that there's a lack of exposure in enough of this area and enough of these areas and throughout the image that it looks grainy. Okay. So anytime you see quantum noise, um, you'll probably need to repeat it and increase your technique. Your mass needs to go up. Now, a caveat here, sometimes the monitor at your workstation will contribute to image noise. So if you take an exposure and it looks like this, grainy in its appearance, zoom in on that monitor that you're at, the workstation. Zoom in on that image. If it looks better, then your exposure was fine. You don't need to worry about it. If that grainy appearance just looks bigger, it gets bigger as the part gets bigger, but still looks grainy, that's an underexposure. It probably needs to be repeated. Signal to noise ratio is the ratio of the usable factual signal to the amount of noise within the system that's normally there. Under all circumstances, there is a certain amount of noise within an electrical system, period. The object of our electronic imaging devices is to get enough image information, a larger imaging signal to outweigh that noise so that we can see the details. Very simply represented in this picture here, we have a signal to noise ratio of 0.5. Okay. That means that we have, for every two pieces of image information, we have one piece of noise. Okay. And so you can see we don't get a lot of differentiation between the signal, the actual signal, and the electronic noise in the background. Going to a 1.0, it's the same thing here. Okay. So we're this factor, we've got this ratio of 1 over, so 2 over, it would be, no, 2 over 1, it would be 4 over 2. 4 over 1, 3 over 1. The ratio equals 1. Let's put it that way. So now we've got one bit of information with one bit of information from our signal and our noise. Now we can start to see a little bit. But as you notice, we go from 0.5 to 1, then we go from 1 to 2. Now we can start to see more information. Okay. So the signal to noise ratio that we have needs to be to a point where we make out a lot of anatomy as opposed to seeing a lot of noise in our images. The higher the signal to noise ratio, the better the visibility is going to be. Our television camera tubes that we used in fluoro gave us about a 200 to 1. Our digital flat panels give us about 1,000 to 1 signal to noise ratio. So we are obviously able to use less radiation, one, but the technology is such that we get a much better image with the same amount of radiation. This says that if the signal to noise ratio is low, you can use your mask to increase the signal to noise ratio and remove that image noise. That's one of the reasons why, if it's grainy, that's quantum model. There's more noise there than there is radiation signal. So all you have to do is put more radiation to it. The problem with that comes to the technologists not being adept at technical factor adjustment. And so now, in order to avoid any noise on any image and being chewed on by the radiologist for noise, they go ahead and just go up in their technique and they use exposures factors that are much higher than they should be using. That's what dose creep is. It's the um, tendency for a technologist to increase the technique beyond what is normal to decrease noise. Couple points here. Markers. Using markers, we need to use small markers. I know I've seen texts with markers like that big. You need to use as small markers you can get away with, because that information gets pulled into the histogram in our digital images, and that information influences the way that the image is rescaled. Um, so, use a small marker if you can. Make sure that it's not in the anatomy. So now we're looking at image evaluation here. Make sure you're marking the correct side of interest. It needs to be in the collimated area. It needs to be in the light field. Um, it's helpful to have your initials in there as well. Remember that it should be paid. This is for CR and film. Okay, you can't do this with a CCD system or a flat panel system. But with film and CR, you need to shoot the markers at the same time you're shooting the anatomy. Um, that depends on what your facility asks for. If I have a beaded marker, I'm not going to bother with an upright marker to go on it. So, I mean, it's just kind of depends on the protocols at each facility. The ARRT doesn't specify that you have to do that. Mark both ways. Um, we want to use lead markers. They need to be routinely used. You can use electronic annotations, but they're not preferred. Early PAX systems, if you annotated it at your workstation and sent it to PAX would remove that information. And so when it ended up being stored, it got stored without the annotation and the marker that the tech put on there. Systems are much better now. The annotations do flow over, but that is still a point of contention legally. If an image goes into court, that is something that they will go after, is that, well, why didn't you use your marker? You should have used your marker. How do we know this is the left side? How do you know it's the left side? And with film, we were able to defend that. We could, because of where the name blocker was and the cassettes and the physical attributes, you could figure out what was left and what was right on a patient without it being marked. Can't do that with digital because there is no point of reference except your marker being placed. Remember that x-rays are legal documents. Electronic markers can be manipulated, and like I said, that is a point. Don't be confused here saying, well, if I don't put my marker on it, then it can't be used in court. It most definitely can be used in court, marker or not. Okay? It's just for your benefit, you're better off marking it and marking it correctly. Exposure indicators. These are the numbers that the manufacturers present to you and say, okay, when you do this, you need to be within this number and this number to know if you've got a good exposure. That's great. We need that. But there's no industry standard. Okay. We use the S number, the E number, the deviation index, EXI numbers. There's all different kinds depending on the manufacturer, and they don't work the same way. A low S value means a high exposure. A low DI number means a low exposure. It varies, and it's up to you to find out which it is. Now they're important because they give a description of the amount of work the computer does and where it is that you are exposure wise for that particular examination. Now, again, there is a range. Okay. So here's a question for you. If we look at this image here, and this is the exposure indicator. All right. We've got this area in green, an area in red, and an area that's yellow. Yellow indicates low, red indicates high. Now, if this is our exposure in the green, where do we want to be with our exposure in relation to that green? Yellow is low. Where should our exposure be in that green range? Yes, we want it in the green, but where in the green? So target. Well, the green is the target. The green is the target. And that target is, it's a specific size. So where do you want to be? You want to be closer to the red, you want to be closer to the yellow, or you want to be closer to the middle of the green? Yes, red indicates over, yellow under. Middle of the green. Okay, so if you answered middle of the green, why do you want to be in the middle of the green? Closer red gives you more processing wiggle room. That may be true, but I'm not doing any post processing for me. The radiologist is the one that needs to do the post processing. While closer to the red does give you an increased signal, we talked about that, yes? Right, closer to the red means more signal. Okay, but that green is this big. We operate under the principle of what? What's our principle regarding radiation protection? As low as reasonably achievable. So if there is green below the middle, that is still, it's green, so that means it's good. That means we should be using less radiation for that image, right? If we're keeping with ALARA, we can achieve lower exposure and still be within the range, the green range, right? Being in the middle, okay, you're in the middle. Being closer to red, you've just given them, I mean, there's less signal to noise ratio. Yeah, you definitely want to be closer to yellow. You want to be still within the green, but closer to yellow. Yes, there is that possibility. If you are green yellow, you risk a reshoot because of noise. But according to the American College of Radiology, it should be up to the radiologist to determine how much noise is acceptable. Yes, the manufacturer gives us ranges to be in. And yes, we have control techs that ultimately say, no, do this over, do this over, do that over. Ultimately, the radiologist should be consulted and you should ask them, is this acceptable? Can you make an accurate diagnosis with this noise? Okay. And honestly, if you question the amount of noise that's there, it probably needs to be repeated. Okay. So it wouldn't hurt to be closer to that green yellow border. And it would still be a perfectly diagnostic image for the radiologist. And that's my trouble with the exposure indicators. There's a wide range with an S value. If the range is 300 or 200 to 400, if that's the range, the difference in exposure between 200 and 400 is a factor of 2. So if I could get something done with half the exposure, that's what I'm going to do, right? The noise, this one repeats itself. An increase in mass is going to give us a clearer picture. You can increase your mass. Some of these systems can compensate for 50 times over exposure. So that's where dose creep comes into play. That's where, okay, we want to be closer to the red so we have more room and there's less noise and blah, blah, blah. That, okay, but you could do it with much less and still get a diagnostic image for the radiologist if we're staying with ALARA. Gross overexposure errors cause a saturation of the detector and we get a loss of information. Like I said, digital systems can compensate for up to 50 times an overexposure. This one is more than 50 times the overexposure. In fact, anatomy's been lost. In a chest X-ray or an abdominal X-ray, if we oversaturate in that anatomy, we run the risk of burning through pathology and having it not be appreciated by the radiologist at all because we burned through it. Remember the differences of adjacent densities, structures that are adjacent to one another is the definition of contrast. We used to have one, it was just contrast. Now we have two: subject contrast and image contrast. Subject contrast, we don't see. We don't appreciate subject contrast because it has to do with the transmission and absorption of the x rays through the body. Okay. We don't see that. What we see is an image contrast that is scaled and is controlled by the computer and software. Okay. Long scale or low contrast is a long scale. Keep your L's together. High contrast is a short scale. This means that there's a long scale means there's a lot of shades of gray between black and white. Uh, a short scale means there's very few shades of gray between black and white. Looking at your image evaluation, look for spatial resolution. Does that look blurry? It looks blurry to me. That would probably be repeatable. Motion, big thing. And we've discussed this before. Minimize our distortion. Okay. We're always going to have some level of distortion, be it size or shape, but we can always minimize based on our two-part film alignment and proper SIDs and minimal OIDs. Markers, make sure they're on there. If you've got scouts, post void, the special markers for special views, make sure those are on there as well. Look for artifacts. Look for artifacts. Some of these, you know, some of these can't occur with digital. This one can't occur. You can't do a double exposure on a flat panel. Once you make the exposure, you get an image and then you're going to re-expose it anyway. This is going to happen with film or CR. This is going to happen with CR, this white line. The light that comes off of the image plate when that laser strikes across it, if there's a piece of dirt on the light guide that pulls that light coming off the screen into the computer, then there's no information that's going to be there. And since there's no information, it shows up on our image as a white line. That reader needs to be cleaned. Cassettes with film and CR, this can happen there too. Dirt or dust can get in there and interfere with exposures. The moi here is that wrapped around aliasing issue. This happens with an improper grid alignment or an improper scan of the CR plate. This does not happen in digital DR with flat panels or CCDs. This can also be a result of a monitor too. So just like noise, if you zoom in on this image and the artifact disappears, it's not in the image, it's caused by the monitor resolution, and it's good to send on. However, if you zoom in and the lines are still there, that is in the image itself, it will transfer over to PACS and you will have to repeat it. Okay, but if you zoom in and it disappears, it's good to go to PACS. Artifacts, CR. This is a CR artifact, the ghosting here, where you have another L spine. Looks like there's a marker here as well. So we've got an image on top of an image. Ghosting is a result of an improper erasure of a CR plate. Okay, it went through the reader, we got the image, but when it went to reset the image with the bright white light, all of the energy didn't get taken out of it and removed, and it remained for the next image. Not quite the same as a double exposure. Exposure field recognition errors. This is a CR artifact. When it can't identify four borders around an image, it assumes that all of the information, even that scatter, even the scatter that's generated, you can't see it here because it was properly, they said, oh, wait, these values are much, much lower. It doesn't pertain to the anatomy. That has to be scatter. We're going to make them white clear. Here, it just said, well, all of this is anatomy. And so when it rescaled it and adjusted all that with the lookup table, we end up with a dark image. Okay. This can be fixed. Reprocess it. You don't have to repeat this exam. Damaged plates can cause dead pixels in our DRs and CR. Two more here. Some other general artifacts. This is lines from a stationary grid. I know it says from misaligned, but it's not really misaligned. It's a stationary grid. Those are just going to show up, period. It's not the moire. The moire has that wavy line appearance. This is an artifact from a positioning sponge placed behind the patient. I can't see it on this one, even on my television here. I can't see the braids, but digital imaging and digital receptors are so sensitive to the amount of radiation. Their DQE is off the chain. Their dynamic range is extremely long. So things that we couldn't see with film, things that we couldn't see with CR, are show up with our flat panels. So make sure we get our patients properly prepped. Misalignment of the exposure field, we get, again, histogram errors. The scatter that's generated outside or by the body is enough to cause an exposure field recognition error in this CR. Again, this is not going to happen with DR. Unless there's a software issue, as it says there. This is the last slide for the night, y'all. Background radiation. This is on a plate that wasn't used. The rule is for CR, if a plate hasn't been used more than 48 hours, it needs to be run through a eraser cycle before it is utilized. Okay, 24 hours is better, but they're very sensitive to exposure, and they're even more sensitive once they've been exposed. So make sure you make an exposure with a CR plate, get it out, get it protected, and keep it away from excess radiation, and process it within the hour. Once it's been, the image has been stored there for an hour, the energy starts to dissipate and the image will lose its integrity. And that's it for tonight, y'all. I appreciate you hanging in there. It was a long one. Hopefully I didn't bore you. This stuff, I enjoy this stuff. This, image production equipment, that's kind of where my heart lies as far as our field goes. But if you have any questions, make sure you email them to me. Thank you very much again for being here and for your attention. Good luck. Work hard. Okay. Have a good evening and a good rest of your week. Bye bye now.